Hi, April. Hi, April. Hi, Paula. Hi, Joanne. Oh, wonderful. Nice to have you, Joanne, from the DFPA. Great to have you with us. Hi, Ilas. Hi, Chris. Siri from SRHR, welcome. Paula, hi. Carla, hi. Oh, wonderful to have you with us, Carla. So greetings, everyone who's joining. We're giving everybody a few minutes to join. As you join, it'd be great if you could introduce yourself in the chat so we know who's with us. We're going to be recording the session with everyone's permission. Hi, Patience. Hi, Tapiwa. Hi, Carla. Welcome. Karsta. Excuse me,
Thank
Karsta.
you.
There's Chris. And Tambiko, hello. Hi, Alex. Hi, Christina Padilla. Hi, folks who are just joining us. We're going to give ourselves a few more minutes to gather. If you could please write your name and your organization in the chat room so we can all see who's with us for this conversation, that would be great. Thank you. Hi, Comfort. Hi, Lena. Hi, Meti. I see you there, Lorelei. Shh. Great to have you with us. FP 2030, first time I've seen that in writing. Welcome, Lorelei.
Thanks, Christina. It looks nice, doesn't it?
Yeah, it was funny. It was like the big reveal, don't call it FP 2030. And in the end, it's just the best thing to call it, right? Everyone understands it. So, well, listen, it's coming up on 8:03. I think we should get started. We're going to record this. It's great. I feel I'm looking at the names of folks here, and I feel like I'm seeing my extended family of health providers, practitioners, program managers, researchers, advocates who've been working to advance universal access to sexual and reproductive health. And a lot of us really joining forces over the past few years to build the evidence case and really advocate for more and better investment in sexual and reproductive health in crisis. And that's what we're going to be talking about today. And I'm looking out at the mix of folks here. We have folks coming from a human rights perspective, other folks from a very technical health perspective, public health, some of our humanitarian colleagues. There's also quite a few people who wrote and said they'd like to be part of this conversation but couldn't join. So we're going to share this with them as a recording. But I'll go ahead and get started. Oh, wonderful to have you with us, Bushra. Okay. So my name is Christina Weggs, and I work for CARE. I'm our Global Advocacy Director for Health, Equity, and Rights. And I have the great privilege of moderating this panel today, focused on innovations for advocacy and accountability to ensure sexual and reproductive health and rights in crisis. And as I was working with my colleagues who will be sharing their work today, we were thinking about some core questions that I think a lot of us have been mulling over the past few years. How do we ensure universal access to sexual and reproductive health for all people affected by conflict, natural disasters, and pandemics? When people are on the move, healthcare systems and supply chains are disrupted, mobility is restricted. We're seeing a lot of times in humanitarian response, sexual and reproductive health is deprioritized, or health and financial resources are going to other services during times of conflict and crisis. So what can we do in these very challenging contexts? What systems can we set up to monitor and address rights violations and gaps in SRH services? How can we provide remedy for individuals who have been denied services, but also help change systems to ensure that everyone's sexual and reproductive health rights and needs are met? And how do we do that in these very challenging settings? You know, in the context of COVID, we're seeing health systems disrupted and overwhelmed. We're seeing mobile and outreach services disrupted, people's mobilities being restricted by lockdowns, and health services may be derailed when health systems are overwhelmed. In these contexts, how do we break down, or how do we identify these breakdowns in access and quality, monitor and address them in real time, and change systems so that they really deliver for everyone? And then also, how do we keep up the energy for advocating for policies and resources to keep sexual and reproductive health and rights prioritized? So these are some of the questions that my colleagues and I were mulling over as we pulled together this presentation. And I'm going to hand it over to them now. We have a pretty critical mass of people who've joined. So let me begin by introducing our first set of presenters. We're going to be here. Could you move to the next slide, Abby? So for our first presentation, we're going to be hearing about innovations to ensure rights-based accountability for sexual and reproductive health in humanitarian settings. We're going to be hearing from our colleague from Center for Reproductive Rights, Grady Arnett. She's the manager of legal research at the Center for Reproductive Rights. And she's joined by Charles Otema, who's her partner in this project. He works for CARE International in Uganda, where he's the Sexual and Reproductive Health and Rights Coordinator. So let me hand it over to you, Grady and Charles.
Great. Thanks so much, Christina. Well, good morning, good afternoon, good evening to all of you, wherever you may find yourself. It's such a pleasure to be in this online space with you all today. As Christina mentioned, my name is Grady Arnett. I'm the manager of legal research at the Center for Reproductive Rights on the Global Advocacy team. And for a quick introduction for those of you who may not be familiar with the center, The Center for Reproductive Rights is a global organization that uses the power of law to advance reproductive rights as fundamental human rights around the world. And I'm really excited to share some of our perspectives on this work, along with our partners at Care Uganda that we've been working on over the last 6 months today. So with that, I'll just hand it over to Charles and he'll kick us off with some introductions and context. Over to you, Charles. It looks like you're muted, Charles.
Yeah, thank you so much, Grady and team on board. Good morning, good afternoon, good evening, everyone. As Grady has said, I'm called Dr. Charles. I work for Care International in Uganda, based in West Nile, where they're hosting the largest refugees from South Sudan. So basically, to start with the current context, and for those who might not know the current programs in Care International in Uganda, Care International in Uganda is one of the leading humanitarian organizations that is supporting sexual reproductive health services in a humanitarian context and also in the development context. It implements in over 72 districts in Uganda, and it also addresses, most of its program addresses key drivers of poverty and social injustices in Uganda, including gender inequality and gender-based violence in emergency and humanitarian contexts. As we know, Uganda is one of the leading countries that host the biggest number of refugees. And as I talk now, currently we have over 1.5 million refugees in Uganda. And basically, Uganda is also known and it champions the issues of integrating refugees. It has an open door policy where refugees are integrated into its services. For instance, we have the health sector integrated refugee response plan that gives opportunity or gives an open ground for refugees to get services in all the health facilities within Uganda. So the current pilot project that we are talking about, it's based in Adjumani and is being implemented in a settlement known as Pagiringa, which hosts over 200,000 refugees. Back to you, Grady. Thank you.
Thanks, Charles. Next slide, please, Abby. So sort of building on the context that Charles has provided and some of the global context Christina alluded to earlier, lack of accountability for sexual and reproductive rights violations is a key feature in humanitarian settings. And we know from our research and the programmatic work at CARE that affected women and girls do not have the adequate access that they need to meaningful and effective accountability mechanisms to protect and promote their reproductive rights. And in a rights-based approach to providing SRH services, but also in the enabling environments that allow access to quality SRH services and information, accountability is not a one-time assessment or action, but rather it really needs to be embedded within formal and informal structures and in what we use in our work and as the conceptual framework for this project as a circle of accountability. And this is drawing from a framework from a report done by the Office of the High Commissioner for Human Rights. So these gaps and reflections are ones that both the Center for Reproductive Rights and Care Uganda were asking when we were exploring options for partnership to address accountability in humanitarian settings. And from field level staff, like Charles and conversations with him and to the country director level, Care Uganda was sharing with us that they were hearing complaints and concerns from women and girls during evaluations and field visits. And these included lack of quality services or stockouts, but felt that there were limited feedback and accountability loops in place for these complaints to be systematically addressed. And at the center, we really wanted to understand what kinds of contextually relevant models could actually deliver on rights-based accountability through the translation of international, regional, national level human rights standards and principles. And we wanted to do this through a programmatic rights-based framework. So through our partnership and a design process with refugee and host women leaders in Pagiringa settlement, we developed a mechanism that focuses on what we think are the key implementation gaps. which first is an analysis and response to SRHR complaints using the human rights framework. And second, and related to the first, is ensuring access to effective remedies if rights are violated. And so I'll turn it over to Charles, who will explain a little bit more about how the mechanism functions and sort of some of the ideas that we came to. So over to you, Charles, and next slide.
Thank you, Grady, for that elaborate discussion. Basically, I want to elaborate more on the mechanism, because from the scoping study that was conducted in 2019, we found out that there are a lot of gaps in terms of accountability in SRH-related issues. So through that, we made it more participatory, where we involved women representatives, we involved the duty bearers, those are the power holders. We also involved other community structures and development partners to actually find out what is on ground and design what works best to improve on the quality of services. So through this, we developed a mechanism. And what does this mechanism do? One of it is it collects and reviews and responds to SRH complaints and feedback. First of all, it has like 3 different components. We have the community council, we have the ombudsperson, and then the community-based facilitators. So if you are to see in this mechanism, it is more participatory and it's integrated. So that means it's community-based. It first of all identifies the issues on ground, then secondly, responds to it, then also brings feedback. So the second function of this mechanism is that it serves to ensure access to effective remedies if rights are violated. So in case we engage these structures on ground that I'm going to talk about, it will be able to have effective remedies if rights have been violated. Then also the third purpose of this or function of this mechanism is to serve and monitor implementation of these remedies that have been identified. Because if we identify these remedies, for us to see that oral actions are being implemented, we must see that remedies are also monitored. Then from the diagram, as Christina has projected on the PowerPoint, we have the first branch, which is the community council. So what does the community council do? So first of all, the community council consists of 9 representatives that are from both the host, that is the people within Uganda, and then the refugee community. Then also it has representatives from implementing partners. We know they contribute a lot in terms of service delivery. Then also it has members from the service providers. So basically this council collects and reviews sexual reproductive health related complaints and feedback, and is also responsible for leading locally generated and driven solutions to address these complaints that have been identified. If this is beyond them, beyond the council, they are able to engage the ombudsperson. So if it needs like independent review, because some complaints are confidential, some complaints need like an independent person to review other than the community, the council is able to engage this ombudsperson. So who is this ombudsperson? From the previous accountability structures that we had, we found that it was not so effective. That's why in this innovation, we had to bring in the ombudsperson so that this person is independent and is able to review other complaints and able to channel them to the duty bearers or power holders, and also bring feedback and make also follow-ups on certain remedies that have been identified. So basically, the ombudsperson is an independent person or a third-party person that is identified and is having high profile in the community. Basically is identified by the duty bearers or the power holders, who helps in reviewing complaints that have been directed to her by the council, and also helps to bring feedback from the duty bearers or the power holders. And then the third component of this mechanism is the community-based facilitators. Basically, these are trained volunteers who are trained by CARE International and also a Center for Reproductive Rights. And basically their major function in this mechanism is to raise awareness about sexual reproductive health and rights, because we know in the community, most women and girls do not know their rights, do not know that in case rights are violated, this is what you're supposed to do. So these community-based facilitators or the volunteers help in sensitizing, and also they help also in counseling in case they identify people whose rights are being violated. They are able to counsel them and also refer them to the different stakeholders or for any service uptake. So basically, those are the three major components in this mechanism that makes it complete. So if you are to see also in this mechanism that we develop with Center for Reproductive Rights, you find that it has also built capacity of power holders. We had found out from the scoping study that power holders did not know their obligation in terms of improving quality and access for women and girls for these services here. So this pilot project has also built the capacity of the different power holders during mentorship, during discussions, and also during trainings that we took them through. And all the aim of this was to build their capacity to be answerable in case rights are violated. And there are a lot of case studies that we also found out, and I would take back to Grady to highlight on some of the case studies that we found out from the project. Back to you, Grady.
Great, thanks, Charles. So next slide, please. Thanks, Abby. So today, the accountability pilot and the mechanism that Charles has just illustrated for you all has reached over 5,000 crisis-affected women and girls with information about SRHR and rights in particular, as well as the pathway for accountability in Pagariña through our mechanism, but also through other existing forums. Since August of last year, this mechanism has collected and reviewed over 50 complaints and feedback related to SRHR. It has surfaced a variety of issues, some of which Christina alluded to again in her introduction, related to remote delivery of SRH services throughout the COVID-19 response and pandemic, to the health center level, which is where we see the majority of the complaints that we're receiving, to more structural and systemic issues that impact reproductive rights and health. And we have a few case studies that we'd like to share with you today. And then the first example that we can share from the findings, the Council for SRHR received a complaint about the marginalization of girls and adolescents from UNHCR's menstrual hygiene kit distribution program. And the Council responded with direct advocacy to UNHCR on these issues, and it resulted in the agency committing to increasing both the number, but also the coverage of kit distribution for improved adolescent accessibility in Pagariña. And this was one of the first complaints that was received by the Council. And as a result, community monitors have been able to follow up and continue conducting their monitoring. And what they found is that there's actually been a longer term sustained commitment of this implementation over the last 4 months. And that's something we'll continue to track. Most of the complaints we're hearing center on the right to the highest attainable standard of health and the 4 components of this right. And you've probably heard this referred to as the AAAQ framework. So availability, accessibility, acceptability, and quality as really the core components of the right to health. And we find the protections for the right to health in national laws, as well as regional and international legal instruments that have been ratified by Uganda and we use in this work in our capacity building with duty bearers. And on the issue of the right to health, the mechanism has reviewed complaints about a lack of available confidential adolescent SRHR services and information. We're also hearing about inaccessibility of medical equipment for women with disabilities and disrespect and abuse by healthcare workers, particularly among refugee women. And on review of these complaints, the ombudsperson's convened her monthly meetings with duty bearers, government and health service providers, which has resulted in the district health office to increase their oversight and monitoring duties at the health center, as well as the facility in charge committing to a review of the respectful maternity care policies in place and resourcing right to health trainings to guarantee non-repetition at the health center. So most responses and remedies to date, as you probably have seen from what I've alluded to, has focused on these guarantees of non-repetition. And this really means, making sure that rights violations are not repeated and that measures like policies or systems changes are put in place to make sure that these violations don't happen again and that they're monitored. But the mechanism has also demonstrated its ability to respond directly to individuals when SRH services are denied. And one example of this we've seen is regarding to the denial of antiretroviral treatment to new refugees coming into the Pagariña settlement. And in these cases, the mechanism successfully reversed the introduced policy that limited ARV access to the existing patients only, which we thought was a really incredible feat and was also accomplished in a really short period of time from when the complaint was made to the remedy actually being executed. And so ensuring this access to availability of quality supplies in the settlement where new refugees are based is critical, but it's especially critical given this moment of severe restrictions put in place on mobility due to COVID-19. And so on that note, and with some really top level examples, I'll hand it back over to Charles, who will share a little bit more of a detailed case study of some of our outcomes. So back over to you, Charles, and next slide, please.
Thank you so much, Grady, for that elaborate example of some of the interventions that the project has responded to. Another example or case study that I can talk about is the increasing number of teenage pregnancies that the project also responded to. As we know that Uganda has one of the highest number of teenage pregnancies. I think the national rate, we are at 25% of all pregnancies are teenagers. And basically this was increased during COVID-19 where girls or the adolescents did not have access to sexual reproductive health for adolescents, and also closure of schools made young girls so reluctant, and of course, sometimes they get this information from school. So during our interactions with the community and during the engagement with the structures, this came out clearly that we need to respond to it. So through our structures, they were able to engage the sub-county officials, and that is at the lower level, and then also engage the settlements during those discussions when they identified this. So through that, the sub-county officials were able to engage in a high-level meeting where they recommended to amend a bylaw. I know amending bylaws in Uganda is not easy, but through the pilot project, we are trying to push for this so that we also prevent the high increasing number of teenage pregnancies, because this has also contributed highly to poor health outcomes for these women and girls. And then secondly, also, it has also put a high burden to the health system, because most of these young girls, when they get pregnant, they develop complications which need referrals, and all those ones are bringing burden. But through the project, we are pushing for this so that they amend the law, and we shall be very grateful when these issues of sexual reproductive health and rights is integrated into the bylaw, which has never happened. So we are still following on this, and we pray that this can come out and it will be like a very great achievement and for the women and girls that are suffering from this kind of complications. So with all this, basing on the early findings, we are exploring more opportunities because we saw this mechanism is so effective. 2, is accessible by the community. Then 3, it has integrated most of the structures on ground where it has the community, it has some, the duty bearers, it has service providers. So we shall be so grateful if we get more fundings to scale this kind of innovations to other settlements, because during our midterm evaluations, we found out from the district health office, that is the person who is concerned with health in the whole district, that if this kind of innovations can be scaled up to other settlements, would be so grateful. With these few remarks, I'm really so grateful for your attention, and we look forward to the discussion. And please do not hesitate to reach out to Charles or Grady for any further information about this innovative project. Thank you, and back to Christina.
Christina, you're on mute.
Sorry, I'm on mute. It's always this dance of who's on mute and who's not, right? Could you put on the last slide for us, Abby? So I just want to give a huge thanks to my colleague Charles and the whole Care Uganda team, and also to Grady and everyone at Center for Reproductive Rights. This has been an incredible partnership. I think that we're really learning a lot together. And I think it's really exciting to see how you have, even in the middle of COVID, because this project really got launched just as COVID area restrictions were hitting, right? That you were able to get this up and going with an incredible amount of community participation and ownership in very rapid time, identifying and addressing individual rights violations and gaps in services, but also really seeing important policy and systems change. So very, very exciting learning. It is 8:28. So what I was gonna suggest is if we could hold all of our questions till the end of the session. Does that sound okay, Grady and Charles? So I encourage anybody, so you can remember, put any questions you have for Grady and Charles in the chat box, and we'll be sure to answer those at the end of the session, where we're going to make some time for Q&A. But thank you both so much for this great presentation. And we're going to move to the next presentation. And in this presentation, we're going to hear about how youth net and counseling based in Malawi, but also CARE, have been partnering with community groups and especially youth activist networks to sustain access to rights-based family planning in the era of COVID. And we'll hear specifically on how they have been able to work on ensuring ongoing accountability mechanisms for right-based family planning, but also successfully advocating to sustain investments in family planning, even in the middle of COVID era fiscal restrictions. So I'm going to hand this over to the team to present. We're going to hear from Patience Mwale and Tapiwa Muntale, who are my colleagues from CARE Malawi. And we're also going to hear from Comfort Chizinga. Comfort Chizinga, Comfort knows I always mispronounce her last name, who is a leader at the Malawi Youth Net and Counseling Network, and is also the FP 2020 Youth Focal Point. So I'm going to hand it over to the three of you to share your work with us.
Thank you, Christina, and thank you, Uganda team. Good morning, afternoon, and evening, wherever you are. It's a delight to meet again, just to discuss issues around sexual and reproductive health rights. I'll be sharing I'll start with the context of Malawi as a country. You should know that as some bit of context around sexual and reproductive health and family planning. The country's goal is to promote, through informed choice, safer reproductive health practices by women, men and youth, including use of quality and accessible reproductive health services. With 29 districts the country has, the Malawi government is providing comprehensive SRHR services in line with the national and international policies, protocols, and agreements, such as the 1994 Cairo Population and Development Conference, FP 2020 commitments, as well as the Maputo Plan of Action. And within this context, strides have been made within the country, where the country has managed to have 48% of women of reproductive age who are using modern contraception methods as of last year. And also the country has managed to reduce maternal mortality rates and infant mortality rates in between. Even though when you look at the stats, you'd see that they're still high compared to the region, they are pointing towards a positive trend. So within this context, CARE Malawi currently works in 12 districts across the country on programs that are supporting government to address key drivers of poverty, social and gender injustice, as well as SRHR within that context. So another aspect that you have to pay attention to, you'd say that however we've made all those strides, we've achieved so many things, disasters tend to retrograde some of the strides made, and most of the times health services are affected the most. For example, we've had Cyclone Idai hitting 15 out of the 21 districts that the country has, and a lot of health services were affected. SRHR was the worst. Furthermore, COVID threatens future of Malawi's programming and interventions. Ultimately, it might erode the gains that we've made, because what we observed was that during the COVID-19 period, we have seen more adolescent girls, more especially at risk. We've seen closure of schools with other factors having contributed close to 11% increase in teenage pregnancies from January to August 2020. Comparing the same period the previous year, there was that 11% increase, which is quite unfortunate. In between, we've seen 50% child marriage rates increase. We've also seen 20% increase in girls' sexual abuse. Second, next slide, please. So zeroing into some of the work in this context, CARE is working in sustaining the rights-based family planning in the era of COVID by driving accountability and growing domestic financing. CARE Malawi in this context has been using community scorecard, a person accountability-driven approach, which I will just highlight in a nutshell what it does. Basically, the process brings together users in one hand, for example, women or youth, and also service providers on the other hand, who are usually government officials, parliamentarians, or any other NGOs within that context and in that area. The community groups of peers assess services, identify issues, and make an opinionated score of the identified service. So for instance, there might be issues identified that would look like at availability of family planning commodities in a range of method mix that a facility or a district is providing. So in that local context, communities and service providers will be assessing that. Concurrently, and separated from users, the service providers will be doing also the same. And they'll be scoring and assessing based on their opinions and perceptions. This culminates into interface meeting where you find that communities, service providers, and government officials would come together to discuss the different perspectives that are coming from the issues identified and the rights violations that have been pointed out. Joint action plans for implementation and ongoing monitoring and evaluation of the mutually agreed plans is done for accountability purposes. That's why the accountability. So after the interface meeting, that platform provides opportunity for a joint action plan, and then the monitoring aspect is the one that empowers the community to take part in what has been identified. What is exciting about this step is basically that the different community groups and service providers generate locally relevant solutions based on their own priorities and preferences. For those issues that are beyond local solutions, you'll find that they're escalated to district or national governments. And citizens and service providers will continue to meet regularly, maybe every 3 to 6 months, through interface meetings just to track progress, shift and iterate their action plans where necessary and depending on need. Some of the key results in one of the districts in Ncheo indicated increases in trust between service users and providers, and also increase in service utilization, which saw a 57% significant increase in the use of modern contraception. This was quite an achievement because we use the randomized control trial just to understand the context at which the process can improve service utilization. So in a nutshell, I would say the approach is designed to empower citizens to understand their rights and entitlements, equip them with processes and tools to monitor how resources are allocated, how services are delivered, and demand that duty bearers respond to the needs and fulfill their rights. The strength of the process lies in providing the tools, a platform, and a voice for those conventionally who will not speak in a group of those in power. For example, the youth and the adolescents and even women. In most of the cultural contexts, you'd find that they're not able to articulate their ask in such settings. I'll hand over to my colleague Tapiwa, who will take you through the adaptation made on the process.
Thank you, Patience. I'll basically take you through, like Patience explained, an adaptation of the process. So we did the community scorecard, but remotely. So from away from the community. When the COVID era lockdowns and mobility restrictions limited the ability of different stakeholder groups to meet, CARE set up an SMS and WhatsApp platform through which groups of women, men, and young people and community leaders shared what they were experiencing and hearing about in their community in terms of family planning as well as COVID services. We set up a similar virtual groups with service providers as well. We sent out questions and prompts to invite them to share what they're experiencing and seeing in their community. Through this, we heard from different groups about the realities of accessing SRH and FP services during COVID-19, and including information about stockouts of contraceptives, reports on the halt of community outreach clinics,
Have others lost a P, or is it just me?
Yes, we did.
Okay. Tapiwa, if you can hear us, maybe you can turn off your video and just do the audio. Patience, maybe you could text it.
Yeah, let me try to.
Okay. Let's give it a minute, everyone. This is the world of COVID and remote, and this is a beautiful story. So I want to make sure that we are able to hear from Tapiwa. So bear with us for a minute, please. I'm wondering, one thing we could do while we're waiting to hear from Tapiwa to join again, we have some questions for Grady and Charles. How do people feel if we maybe take time to ask them those questions, and then when we can bring Tapiwa back on, we can hear about how community scorecard was adapted? Tapiwa, are you with us?
Yes, I'm back. Sorry about that.
No worries. This is the age of COVID and connectivity. So we're very glad that you are with us, and handing the mic back to you. Thank you.
Okay, so I don't know where it cut off, but
I would just start from the beginning.
Okay, no problem. So basically, I'll be explaining the process Patience explained, but how we did it remotely. When the COVID era lockdowns and mobility restrictions limited the ability of different stakeholder groups to meet, CARE set up an SMS and WhatsApp groups, an SMS platforms and WhatsApp groups through which groups of women, men and young people and community leaders shared what they were experiencing and hearing about in their communities in terms of access to quality SRH services as well as COVID-related services. We set up similar virtual groups with service providers as well. We sent out questions and prompts to invite them to share what they're experiencing and seeing in their community. Through this, we heard from different groups about the realities of accessing SRH and FP services during COVID-19, and including information about stockouts of contraceptives, reports of a halt in community outreach clinics, which in turn affected youth access to contraceptives, and fears and misconceptions about COVID-19 and the stories about how so many community health workers were becoming sick. Again, we heard these stories from both community groups as well as health workers themselves. As they came in, we could see which groups were sharing and what their perspectives were on the situation. We synthesized and organized all the input we were receiving from community members and health workers on the ground and organized a call-in radio dialogue between community members, frontline service providers, and district health officials in Cheo. However, the program was aired nationwide, so other people from different districts were able to call in. The picture that you can see on the slide is an SMS that we received from a youth member, part of the youth groups that were in this process. He or she explains the stockout situations, the family planning commodities not being enough, as well as he recommends that peer distributors would be a good way to reach the youth with family planning commodities, and in the sense that it would make them comfortable from receiving these from their peers. Next slide, please, Abby. So I'll take you through the key issues that came out of this process and some of the outcomes. So one of the things that was complained about over and over were the stockouts of PPE from the community health workers and contraceptives from the community members, especially long-acting ones. There was a mention of barriers to youth for youth access to youth access of youth-friendly health services, especially discrimination due to FP stockouts of discriminations of youth by community health workers due to FP stockouts, as well as a halt in community-based outreach and inconsistent health services, considering that some were getting sick, some health workers were getting sick as well. There was also a spike in adolescent pregnancy and early forced marriages. I'd say some of the outcomes from this process were that there were explanations on some of the challenges with service delivery, especially in terms of stockouts. And it allowed the Care Malawi team to elevate real-time data from the front lines into district and national COVID SRHR planning task forces. Moving forward, CARE hopes to sit on the government task force for the COVAX distribution to push the importance of community engagement in this time. Thank you.
Comfort, can we hand it over to you now to tell us a little bit about how UNECO has been building public support for universal access to SRHR?
Yes. Yeah, I think most of the things have already been explained on. Mainly, I'm just going to focus on how, as advocates, we're able to amplify our voices, specifically on the budget for family planning commodities. So we're able to conduct different community dialogues where we're able to bring in different community leaders as well as young people. Basically, our main focus was to make sure that our message is being held from different directions, because we knew that regardless of how many times we keep telling them to try and increase the budget, if it's not coming from a whole range and different people, it will not bring in any difference. So we're able to conduct different community dialogues where we're able to bring in different traditional leaders, religious leaders, as well as youth, to be able to for them to be able to understand the importance of the increase in family planning commodities budget and how it would affect a typical girl in the village. But apart from the community dialogues which we conducted, we were also able to use our radio. As the first slide earlier highlighted, I work for YouthNet and counseling, and we have a radio. So we're able to use that to our advantage, whereby we're trying to advocate for different stakeholders to be able to come in, as well as youth to be able to come in and be part of the conversation to negotiate for that increase. But besides that, I think Tapiwa was earlier explaining on how we're also using the SMS. We're able to use phones and different groups for us to be able to engage young people on the importance of a budget increase. Basically, we're trying to trickle it down for a young girl, an adolescent girl, to be able to understand that a minor increase in the budget would mean that she'll be able to access different services. The screen that Tabiwa earlier showed that a person was trying to complain that they couldn't find a range of commodities. So we're trying to make them understand that once we have a range in different commodities, they'll be able to access whatever commodity is most suitable for them. In which case, indirectly or even directly, it will help to minimize different early pregnancies as well as unsafe abortions. So basically, we're trying to use different platforms for us to be able to reach out to young people in the community as a whole, for them to join in the conversation and trying to advocate for a budget increase on commodities. Yeah, over.
So picking up from my colleague, Comfort, as earlier on introduced by Christina, I and Comfort sit in the FP 2020 National Engagement Group, Technical Engagement Group. So within that, it accords us the opportunity to learn from others and also to move certain pieces that are lacking from the communities. And one of them that we had identified was the issues to do with the family planning and a budget line for the reproductive health department. The department annually looks at its national budget to determine the funding for the future year. So for the fiscal year June 2020 to July 2021, and with the onset of COVID-19, CSOs discovered that the budget line for commodities specifically was significantly cut. From the proposed 250 million Malawi kwacha to down to 175 million Malawi kwacha, without any explanation yet. And the previous financial year, it was the department was funded around 186 million. So you'd see that there was even a drop, a further drop from the previous funding. So CSOs immediately was like, no, I think we need to do something about it. This budget line is what the government committed to include and sustain as part of its FP 2020 commitments, and only contributes 2 to 3% of its annual consumption for family planning commodities in the country. The majority is donor funding. So if you can imagine, already you are contributing domestically 2% and then you're deciding to cut it down. It didn't sit well with so many quotas, and reproductive health was was part of it. So they reached out to various CSOs, and it did not help matters that the cuts were being made with COVID-19. Coalition of CSOs joined forces to fight the budget cut, and using data from past trends on family planning, COVID-era stockouts reports from the grassroots, spikes in GBV that have been articulated by my colleagues, in adolescent pregnancy rates that I indicated earlier on. We did issues paper. These issues paper were submitted to the protection cluster as well as the reproductive health cluster. And these papers basically were trying to compile and document the cases that we're talking about. We utilize this data to inform our advocacy piece. And basically, we're trying to understand how much of this budget line is contributing to the family planning commodities, and what is the status of the family planning uptake in the country, and tallying that with the documentation that's coming on increases in teenage pregnancies and fresh evidence from the remote community scorecard articulated by my colleague Tapiwa and some of the advocacy piece that UNEC was doing. And other CSOs also contributed to that evidence, like options, and some of them who are just highlighted on the picture that you can see down there. So we had local and international organizations joining forces to move this piece. And government, we took advantage of the government relationship the CSOs have, and the meetings were initiated with the reproductive health department to understand the context further. And then we further conducted various engagement forums and meetings with the department, parliamentarians. Basically, there is the Parliamentary Health Committee that we engaged, and the Women Caucus, trying to make our case understood. And also trying to lobby them, knowing that their policy holders, as well as budget approvers. And also officials from the Ministry of Finance, Economic Planning and Development as their budget compilers. Basically, they're the ones who receive all the departmental budgets and eventually compile it. And if there are any budget shifts, they're the ones who know that this department maybe has got more on this aspect, maybe we can shift to this. So we talked to them, presented our case, and made them understand and lobby them to say, can you please at least maintain or increase? Because what we're asking for basically is an increase. That was the expectation, to say we need to be progressing. Learning from COVID, there are so many challenges that we saw just basically procuring PPE because we're so much donor dependent, we couldn't find some of the stocks. Why can't we start looking inward rather than outward looking? We utilize all these advocacy materials, plus the advocacy materials from FP 2020, and as well as we engaged media platforms to lobby citizens to rally behind us, as Comfort has articulated: radio, print media, and social media. Ultimately, we succeeded in increasing the domestic financial planning, family planning budget to sustain access during the pandemic and beyond for the year. But basically, of course, we didn't get the ultimate that we wanted, the 250, the initial ask, but at least we managed to get the 200, which was an increase from last year, which was 186. I have to also point out that the devastating impact of IDAI and COVID-19 increased the political will to listen and to build more resilient health systems. So this really, at the end of the day, helped us to articulate, but the evidence coming all from the community going up. I think some I indicated that when you are doing community scorecard, sometimes you find yourself in a situation where there are some actions that need upper redress. So these are the issues that we're trying to escalate to the district and government and national governments for them to address, to say there is talk out because this is the situation on the ground and you are failing to fund the budget. If we had the budget, at least we would cover such gaps. Thank you so much for the platform and the time to listen. Over to you, Christina.
Let me unmute myself. Abby, would you show the next slide? We'll just really quickly. We'll be sure to share this afterwards, but with FP 2020, we're kind of developing a case study with Comfort and patients and others about this advocacy journey. And then to the next slide, just so we can show people's contacts. And we'll share this out afterwards. I just want to thank our amazing presenters, Comfort, Patients, and Tapiwa. Also recognize Tambiko and Chris, who are colleagues of ours from Care Malawi, who helped develop this presentation and are leaders in this work. We're at 8:55. Originally, this session was actually scheduled for an hour and a half. I don't think anyone has that time, but I was hoping maybe you could stay with us for another 10 minutes so we could answer a few questions. First, just a huge thanks to Grady, Charles, Comfort, Patients, Tapiwa. I sometimes think I have the best job in the world and I get to work with these brilliant, brilliant people. So let me pull up some of the questions that we have. The first question is actually from my colleague, Chris. This is for Charlie and Grady on the ombudsperson. How is his or her mandate strengthened, considering that she acts as an interface between users, providers, and other stakeholders? Is there an MOU, service charters, or guidelines? Could you tell us a little bit more about the ombudsperson, Grady or Charles?
Absolutely. I can maybe start off with some of the conceptual thinking around the ombudsperson. That actually might be helpful when we give some specific examples, which I'm sure Charles can speak to. Certainly the terms of reference for the ombudsperson, but really how Care in the Center is working really closely and providing capacity building for her. But the model is one we're really excited to work with. I mean, this is one that some of you may be familiar with, some not. It's not a universal system across countries or regions. But an ombudsperson is typically someone who has independent authority to monitor government or organizations' activities, and they really represent the interests of the public. And they have a vested authority to investigate human rights abuses or other concerns related to their mandate. And that can be human rights, or it can certainly be a whole host of other government bodies or agency issues. And in our context, we weren't working in a context that had an institutionalized ombudsperson's office. It's something we've seen in other projects that we were really excited to explore more, but that just wasn't something that was possible for this project. But through the capacity building we did with the duty bearers, and Charles really spoke to the specific duty bearers we're working with in this project, they really came along on this journey of understanding the value of an ombudsperson to help address the lack of accountability that they even acknowledged they were seeing in the settlements and host communities, but also to have a resource for them, to have an intermediary between them and the community. And we worked really closely with duty bearers, certainly on capacity building even before this project launched. And I think there was a question about that we can answer as well. But working with the duty bearers to acknowledge the value of this kind of a role, and then to work with them through developing criteria and a selection process for selecting an ombudsperson. At the end of the day, it was really the district level government that selected and brought in the ombudswoman who we're working with on this project. And she's an incredible SRHR advocate and has really excelled and moved forward so many of these response plans. And we're also really lucky to work with her. But the role, it really strengthens the mechanism, because while she works in an integrated way, and Charles gave some really great examples of how she works with the council and works with the community-based facilitators, to also build their capacity, she's authorized with a function to assist constituents to get redress in cases of violations, and when they occur, and they do occur from what you've heard today. And this position it's not formally institutionalized. As I said, there's not a formal ombudsperson's office, but it's one that she was selected and appointed not through a political process, but certainly through a rigorous and objective process led by the government and a series of humanitarian actors that work with the government and make up that host of duty bearers we work with. So I think the evidence base that we're generating really points to the feasibility and the benefits of working with these ombudspersons models, be them in the de facto way that they're designed to be, or innovative, more flexible ways that we can pull the core principles, which are really human rights principles at its core. And we're seeing that in our project. And I think that those are specific ideas and questions that we'd really love to continue to explore. So I think, that's the more conceptual idea of the ombudsperson and the strengthening piece, but, I'll hand it over to Charles. He'll likely have some more specific examples of maybe the terms of reference and MOU and how she does her work.
Thank you, Grady. To add on what Grady has said, the ombudsperson specifically, she's an independent person that was selected by the duty bearers. And to add on some of the roles, she has specifically identified a lot of issues and gaps. And secondly, to embark on our roles, we also gave her terms of reference where she knows what to do and all that. Then secondly, she is also being facilitated. So we facilitate her to do that work. So that means she becomes more efficient. So that's what I wanted to add only, but Grady has mentioned most of the things that the ombudsperson is doing. Thank you.
Thank you. We have a ton of great questions. I don't know if we're going to get to all of them. I want to assure you we're going to save them and make sure that you can be put in touch with the presenters. But I wanted to share another question from Bushra, our colleague Bushra. Wonderful to have you with us. This is for all the presenters, and maybe I'll ask our colleagues from Malawi to address this first. Bushra asks, would you elaborate more for who funded covering the gaps that were identified by the feedback mechanism? So in other words, when you identified a gap, who funded, who was able to pay for changes in the services, I think, if I'm getting this right. And if there was, and also could you tell us if there was resistance from the authorities where you're working in terms of using this feedback mechanism? So maybe we can hear first from our colleagues in Malawi to answer Bushra's questions.
Thank you so much, Busha, for the question. It's quite full. I would say the process itself, the way we conduct it initially, I think as I'm answering this, I think I'll be answering to another question that's coming to say, how do you ensure you're not politicizing everything? Basically, when we are initiating the community scorecard process, the initial phase that I think was projected on them, there was a pictorial. It's about planning and having buy-in. During that buy-in, it's an opportunity for us to lay out the ground and understand the political economy analysis and know who are the movers and shakers, so to call it, in that context. So once you know them, how do you buy them in and them understand that what you're trying to do is to improve a particular service, not to point fingers or to harm anyone within the process. So once you have them on board, and then when you're rolling out the process, in between there is kind of a task team that's instituted that will be tasked to monitor the joint action plans. That task team basically can constitute both service providers and users within that context. Say, for example, around a facility, you would appoint a few service providers as representative and their community members. And in our context, like Malawi, we've that role has been easily falling on HAG. The HAG is like the health advisory committee that normally comprises the communities as well as a hospital. So within that, they're the ones who are the first look for feedback mechanism. Anything that's not moving, they would scale it up. We have also a hospital ombudsman who picks up issues when they are to do with rights violation. The hospital ombudsman is the one who is the next step to pick up those issues and address them. If they are not being addressed at that particular level, this task team is mandated to escalate the issues either to district level or to whichever CSO who was present at that particular day. So you'd find that either parliamentarians would come in, either CSOs would come in to have a role in addressing those action plans. At the end of the day, initially it's about a skill set on how you have the right people sitting at the table trying to address this, but also having the buy-in from the community to say, you have the power to address these issues. Do not fear the service provider because they seem to have the power with them. Power in terms of they have the upper hand in providing a service, but rather sit down, discuss, and then mutually agree on how you move forward on this aspect. I don't know if my colleague Tapio has got more to say. And if Tumbiko is still online, I'm not so sure he can add more to that. Thank you.
And Meti, I hope that Patience was able to touch on some of the questions you had about your work with the community scorecard, and that providers can, or that it can easily get politicized. I hope that Patience was able to address some of your questions around there. We have one more question. I know we're sort of running close on time. From our colleague from our dear colleague Ruben, who's from the Office of the High Commissioner for Human Rights. He asks about, and maybe this is something for both presenters, what were some of the challenges to establishing the mechanism, getting buy-in from different stakeholders, especially if there were negative perceptions about human rights? Just to make sure I understand your question, Ruben, is it that sometimes when you use the word human rights, people are sort of turned off or don't understand what that means? Or I don't know if you want to voice over exactly what your question is.
Yes, thanks, Christina, and thanks again to everyone. It's been really fascinating. No, yeah, the question is really about, sometimes when we talk about human rights, or we use the term human rights, or we talk about some of the principles, there's some resistance by service providers, by duty bearers, by communities as well about, what that means, and, it comes down to some of the points that were raised before as well about the fear of pointing fingers, But of course, we know that it's much more than that. So be very interested to learn more about how we've been able to address some of those kinds of challenges, if you have encountered those kind of challenges, and how you've addressed those. Thank you.
Charles and Grady, do you want to start? And then maybe we'll invite our colleagues from Malawi to address this. I'd be also interested, Comfort, in the language you use in your community work.
Sure. I mean, Charles, do you want to start talking about, how you work with duty bearers? I can also give a higher level overview too, but go ahead.
Okay, thank you so much for the question. Actually, when we started the pilot project, we had a lot of resistance. That was the first thing. But what we did is to engage the duty bearers in a training where they were trained on SRH and sexual reproductive rights. That was the first step that we did. Then also we conducted an inception to describe to them what the outcomes of this project, because what I know from our discussion during that those trainings and everything, we know that the duty bearers or the legislators are actually very quick to bring out laws, but very slow in sustaining them or functionalizing all this. So what we did is to engage them in trainings. First of all, to get the scope of work of this project. Then secondly, also to be able to engage them in where the rights are violated. So there was no much resistance from our side as we were engaging with these duty bearers. Then also what we also did is that for us to make sure that we attain these issues of rights to health, that means issues of human rights should be factored in. So with those discussions, they came to know all about issues around human rights in regards to rights to health. Back to you. Thank you.
Our colleagues from Malawi, do you want to say something about this, either Comfort or anyone from Care Malawi?
Comfort, do you have something to say before I can come in? Okay, whilst Comfort is maybe setting up.
Okay.
Yeah, I can take it up. So basically, as you would understand, the process of community scorecard, the way we've implemented it's basically a process. It's not a tool, it's not. So within that process, you'd find that some of the issues that come out is we have to equip each and every individual who is engaged in the process with the right tools, with the right capacities to manage the process itself, and also to attain the aspired outcomes of the issue that's being addressed. So within that, you'll find that issues to do with understanding rights and duties, normally in that context would just tailor-make them to people to understand that their entitlements, and also how you present them to the various stakeholders would matter. So at the end of the day, it's about presenting the right tools, presenting the right documentation so that people understand. And some of the issues along the way that would be identified, we've discovered is that it's about capacity building as well. You'd find that people are starting from a place where they are behaving as such, more especially for service providers, because maybe they have capacities they are lacking in terms of maybe in a health facility. Most of the times we would find women complaining that they're not being treated fairly when they are receiving a service, more especially the youths and adolescents. They would say, when I present myself at the facility, I'm judged immediately. To say, why do you need a contraception at your age? Automatically you are labeled as a youth. So within that context, what we've tried to do is to work with providers. Is there identifying those gaps? That's where we bring in all the stakeholders to say, if the current project that's facilitating the process cannot address that particular gap in terms of capacities, who are the players within that context or within that facility or district that can come in to provide that capacity. So you'd find that resources are pulled locally. If it's something that cannot be pulled locally, like another CSO complementing that service, or government resources complementing that service, we have to escalate it at national level. And then you'd find that sometimes projects are born out of that. It's so you'd find that solutions that come out of or action plans that come out of it, some might be short term, but some are longer term, because the issue would be either to do with cultural, and you have to deal with so many layers of things that are about rights violation. For example, child marriage. It's an issue that we've seen that it tackles issues to do with how the cultural context plays out and how education services are provided, and poverty issues come into play. So some of the issues, they will be long-term, and you have to strategically sit down with the communities and draft a way forward to say, I think this one is a long-term, let's tackle it this way, whilst this one is a short-term. But it's now about presenting the right tools, the right resources, and the right platform for them to understand that the context which we are working in, this is how we tackle this problem. And having the right people sitting at the table, I think it matters. When you are conducting the process, you have to ensure that you have as many players as possible sitting at the table, so that at least when the solutions are being generated, there is at least someone to pick up one of those issues that are coming out. Thank you. I hope I've answered the question.
Thank you. I mean, this is so interesting. I think we could all, spend the whole day discussing this. I know that I'm seeing that people are needing to drop off. So I wonder if we could end with one question that came to me directly and that I had as well for Comfort. Comfort, maybe you can wrap us up with this. I know that one strength of the work that you and your colleagues do at YouthNet and counseling is you bring a very intersectional approach to how you do your work. And when you advocate for the rights and needs of young people, you are talking about young people in all their diversity, including queer people, including people who sell sex, including people who are living with disabilities. I'm wondering if you could tell us a little bit more about how you approach that. And then also kind of related to Ruben's question, what language do you use? Do you use human rights language, or do you use other sort of terms?
Thank you so much, Christina. I hope I'm audible enough. I think patients sort of also started tackling part of my answer to this. It's all about engaging them from the start. Because, for example, if we're having a project that's coming in specifically targeting the LGBTI, if we were to just introduce activities we believe would be more suitable for them, it doesn't work out. Usually you have to engage them from the start. For example, if you're bringing in a project, you should be able to engage them in the baseline survey for that project. That helps because it's like they'll give you the language they want you to use. They'll give you activities they think are more feasible. A classical example, we had a linkages project recently, which recently ended under UNESCO. For this project, initially we planned that we'll be conducting outreach services, daylight outreach services. But after we engaged them, they were able to tell us that, you know what, with our job as sex workers, we're usually, during the daytime, we're busy sleeping because we're trying to rest, so we're able to work at night. So if you want to provide us with any sort of SRIH services, at least reach us in the nighttime. So that was like driving us. That was driving our activities to make them more suitable for them. We're able to provide the outreach services. We're able to provide family planning, HIV testing, STI screening at night, because that's what they were willing to do. So basically, it all depends on if you've engaged them on the onset. That's what drives the language. That's what drives the activities. That's what drives everything for the key population. I hope I've answered the question.
Thank you. That's so interesting. We can learn a lot from that. Listen, thank you so much for all of these great questions. I want to thank my presenters again. I've learned so much from this discussion. I think it's been a really interesting hour and 15 minutes. Also, we've had a huge number of people who joined us, and I know everyone is exhausted by this nonstop Zoom. So we're very grateful that everyone took the time to join us. We are recording this session and we will share it out. I want to thank everyone for joining and your great questions. Abby, could you move to the last slide? There you go. And we'll include this. Let's keep the discussion going. We're going to keep evolving this work, and we'd love to hear about similar approaches others are taking. And especially, I think we have a really important moment to collectively make sure that these rights-based accountability approaches are being built into the COVID response, so that we're sure that the vaccine is distributed in a fair and equitable way, but also that SRH is not sidelined. I also just wanted to share these two resources. There's a great meta-analysis that was done recently in Conflict and Health, looking at accountability strategies for SRHR in humanitarian settings. And also just to give it a shout out that in last fall, there was a landmark resolution from the Human Rights Council on promoting, protecting, and respecting girls' full enjoyment of human rights in humanitarian situations, including SRHR. And you might want to have a look at that. I know our colleague, Ruben, and others are going to be collecting practical approaches to implement this resolution. So, let us know if we can put you in touch to, sort of collectively start building our toolkit for implementing this resolution. Thanks so much to everyone for joining, and I hope you all have a beautiful rest of your day. Bye.
Thank you, Christina. Bye.
Thank you, Chris.